Hi, this is Brian Wormers recording a lecture for 21st Century Pediatric Nursing, and a welcome into pediatric nursing. So a little bit about me. I've worked peds for numerous years. So I graduated from South Dakota State University in 2000 and worked 1 year peds, 1 year PICU, and then travel nursed, did pediatric ICUs for about 2 years. Came back to Sanford, which was Sea Valley at the time, and did pediatric transport for about 5 years, so rode around helicopters and airplanes. Worked out of peds ICU, and then if there was a call, then we left and went and did that. Was graduated in 2009 with pediatric nurse practitioner, or as a pediatric nurse practitioner, worked with the pediatric hospitalist for 2 years, and then transitioned over to USF and worked here full-time. But then with that, I stayed part-time, worked with peds surgery, and then peds, worked with child's voice for a little bit, which is child abuse and neglect. So I've got quite a bit of experience within nursing. I don't know it all by any means, but I can share some stories, and I can teach you some about pediatrics. So as an overview for peds, I know not everybody's going to be interested in this, but honestly, you'll probably see it more than what you think you will if you're not interested. So, for those people, of course, if you work peds or peds ICU or ICU, or neonatal ICU, I should say, you're going to work with kids, and that's a big thing. But you're going to see pediatric patients in other places, too, that maybe you didn't think about. So, the emergency department, guess what? Kids go there. Family practice, kids go there. Adult ICUs, guess what? Sometimes 15 years and above, kids go there. So, 16-year-old that's been in an MVA, that's kind of a kid. You're going to see pediatrics there. So you might see pediatric patients in a wide variety of different locations that you never even thought that you would. So it's important for you to have a little bit of an understanding with them. I understand that peds can be very polarizing. I get sick of the whole, I like the kids, but I hate the parents type of thing. Well, even if you take care of a geriatric patient, they've got family members, and hopefully you're not just blowing them off. Hopefully you are involving them in the care, and hopefully that you are talking with them and treating them well. So you need to realize that, that those family members really want the same as what you want. You both want what's best for that child, and you need to partner up and move forward with that. Other things, I know some of you have never worked with kids, have never changed a diaper, have never done any of that stuff, and that's all right. You'll learn all that soon enough. The biggest thing in pediatrics, we'll go through some of these big things, is just realize that there's a lot of differences related to development and related to their size and related to, things as they grow and progress through those stages. So little kids are not small adults. You can't just take half the meds and give it to them. You can't. We calculated it all out based on weights and surface area and different stuff like that. You can't just treat a little kid like half an adult, if that makes sense. So they've got their own developmental things that are important with this one. They've got physiological differences. We'll cover that as we go through these different things, but as they are younger, their heads are bigger than their bodies, and their body surface area is bigger, and they've got more percentage of water, but yet their kidneys don't function as well. And their hearts are maturing, and so they get stronger as they get older. Their muscles are the same way. They can't control their necks when they're infants. There's lots of things that are considerations that put kids at risk, and we'll talk about that as we go through. But just realize that kids are different. You can't treat them like adults, and they need that specialized care. So by the end of this, we'll talk about morbidity, mortality. We'll talk about child's health related to that. We'll look at the morbidity, mortality in South Dakota. We'll look at causes of death for kids. We're going to look at promoting family-centered care with patients. We'll look at rights of the child, because that's an interesting topic. And then we'll look at atraumatic care. So childhood health promotion. So what do we do with this? So we talked about, with health promotion for adults, it's a lot of diet and exercise and heart health and smoking cessation. And honestly, we see a lot of the same stuff in kids. So unfortunately, we are starting to see obesity. So if you want some more statistics on that, click this link. But pun intended, obesity is a growing issue within the pediatric population. We never used to see type 2 diabetics. Now we do. I saw an 8-year-old that weighed 350 pounds. And that's got some real issues. If you think about type 2 diabetes and all the complications that you've seen and that you know from med-surg, now think about starting when they are under 20. And what is that going to do to their life progression? And what's that going to do for them cardiac-wise? What's that going to do for them on their circulatory? All those microvascular, macrovascular things that you know about with diabetes, start that when they're in their teens. So you can see the real ramifications of some of that stuff. So morbidity and mortality are really important to us. And what's going on? What's hurting our patients? What can we do to help out with that? So with health promotion, diet, exercise, those are major important things in pediatrics as well. We also talk about suicide. We'll also talk about trauma. We'll also talk about, birth defects and the newborn thing. So there are lots of different issues and concerns with this. But we have to realize that when they have these issues as a kid, this can cause issues for them in adulthood later on too. So if you're really looking at this, so similarities and differences of morbidity and mortality within infants, kids, and adolescents, what you're going to see is MVAs are one of the most striking causes of this. And accidents as a whole are going to be number one for infants, children, and even adolescents, although adolescence is starting to get kind of weird and we're starting to see more of suicide rates climbing and different things like that. But this is all based on development. What are they at risk for developmentally? What are they doing? Especially as adolescents, as they're trying to find their own way, they're starting to separate from their parents, they want to be like their peers. That leads into things like smoking and juuling and illicit drugs and alcohol and drunk driving and sex and all different situations that can cause, morbidity and mortality. So with that, we want to know morbidity and mortality so we can intervene with that and help them out and protect their lives and make sure that they have a happier and a longer life. So looking at the state of infant mortality, South Dakota is not great on this one. Last I knew we were above 7%, which is some of the highest in the nation. I know like Louisiana's up there, Michigan's up there. But if you really look at it, South Dakota infant mortality rates, on this link is like abysmal. I mean, we really should be higher than this, or we should be lower than this, we should be better than this, but we're not, unfortunately. And so there is a big discrepancy. You can click on this article for Native American health and see that morbidity and mortality for the Native American population is even worse than that. If we think about it, just a little fun trivia, the reason why Stanford or Sioux Valley back in the day actually got a flight team initially was because of the maternal newborn team was trying to increase the rates out on the reservations or decrease morbidity and mortality rates for infants. And so that's how the flight team started at Stanford. And then, Avera joined in, and then it branched out to other groups. But trying to help infants, and especially newborns, was a big push. But looking at these national infant mortality statistics and South Dakota infant mortalities, they're not where we need them to be. And of course, if we can save a baby, if we can save an infant, that's awesome. We want to do that. Providing atraumatic care. So we got to do things that are not fun. We have to do that for adult patients as well as pediatric patients, but we really try to be atraumatic in our care. We try to make it as nice as we can. So if we're going to do an IV, maybe we can put some numbing cream on it. Maybe we can use distraction. Maybe we can take them into a safe room or a different room to do this procedure with child life, trying to keep their room safe, trying to keep their parents the good guys. Can we do it? Sure. Just like if we were in our classroom, me and all the other students could grab you, hold you down, and do a procedure to you. We could put NGs in, IVs in, Foley's in, and we could attack you that way. And that language is a little bit harsh, but think about how kids view this sometimes. By all means, we can do that. But what do you think that's going to do for them any other time they come into the hospital, any other time they come into the emergency room, any other time they see somebody in a white coat, any time that they see somebody else in scrubs? It will freak them out. We don't do procedures in their rooms because guess what? If in the middle of the night you were sleeping in your bed, you thought you were safe in a hotel, and then people come in, attack you, put lines in, do painful procedures for you, and then walk out and expect you to sleep, you're not going to do it. It's the same thing with kids. So we really try to do atraumatic care as best as possible. Try to make things like not hurt as much as possible. Sometimes we use sedation, sometimes we use numbing cream, sometimes we use distraction. All that stuff really helps, and it aggregates, and we use more than one thing, but we really try to make the situation as best we can for the kids. So this concludes this lecture. If you have questions on it, please ask, but you're going to see this time and time again for all aspects of pediatrics. And it's not even bad stuff to pull into your adult patients too, of if you can make procedures better, do it. If you need to communicate with family members better, do it. So, alright, I'm going to continue on and record the next lecture, but if you have questions on this one, please let me know.